those were the introductions of these lovely people. Today, they will be discussing the latest research and developments in exercise oncology. So if you have any questions throughout, please don't hesitate to pop your questions in the chat below, and they'll get around to it throughout the presentation. So I'll pass it over to Professor Newton. And I'll just unmute.
Okay, thanks Shannon for the introduction, and Katie and team for the opportunity. Can you hear me okay? Fantastic. I will share my screen. Okay, can you see my screen okay? Okay, I think we're good to go. Scream out if you can't see or you can't hear me. So I've been asked just to talk a little bit about the application of exercise medicine in supportive care, in particular with a focus of on patients with lung cancers. So we're increasingly hearing the term exercise medicine, and this is an important change, I think, in that the fact that we're recognising that exercise is different to physical activity. Physical activity is any bodily movement which uses energy, but exercise in particular is when it's very planned and targeted to produce some benefit in terms of health or fitness. Exercise medicine is being increasingly used in the clinical setting, because it's the physical assessment and prescription of exercise, specifically for the prevention or treatment of injury or illness. Now, we can truly determine that exercise is in fact a medicine because of the enormous changes that occur throughout the body when we exercise. When you exercise, the chemical constituents within your whole system, your blood and all of your tissues, your brain, all of the organs, change markedly. And this is because exercise drives what's termed endogenous medicine. So endogenous means medicine from within, which the body actually produces, as opposed to exogenous medicine, such as taking a pill or receiving an injection of chemotherapy. Now, these medicines within the body are exceptionally powerful because the body is designed to actually receive these messages and to respond to them appropriately. So these include hormones and smaller molecules, which are called cytokines, which are also signaling molecules, which instruct the various tissues in the body, including tumour tissues, including cancer cells, to perform various actions. We also have enormous immune system responses, and many of you will know that one of the hot areas for research around cancer at the moment is immunotherapy. Now, immunotherapy involves actually switching on activating the patient's own internal immune system. Exercise does this exceptionally well, and this is just a normal process of how the body responds to an exercise session or even long-term exercise training. We also see that there's a lot of direct structural adaptation and repair that occurs with exercise, and this is very important because this cannot be achieved through other therapies. There's no pharmaceutical interventions, for example, that can very effectively improve bone health to increase bone density. There's no pharmaceutical interventions which can cause improvement in muscle size, muscle quality, and physical function. But exercise does this. It also produces improvements in blood perfusion and vascular adaptations, which are exceptionally important when looking at some of the mechanisms by which exercise might help to slow tumour progression. But also, this change in blood perfusion driven by exercise is very important for the body to deliver any chemotherapy agents or immunotherapy agents into the tumour, and also to be able to get the body's own immune cells and immune factors, if you like, it's cancer and immunity, to get that into the actual, in the solid tumours. We have extensive evidence that exercise medicine facilitates other therapies. And this is very important, and we'll give some examples later. It also ameliorates a lot of the side effects. And this is where most exercise medicine has been applied in the cancer setting, is to try and reduce the side effects of hormone therapy, immunotherapy, etc. Now, if exercise did none of these things, none of these direct cancer effects, it would still be an essential part of the supportive care of people with cancer, purely because exercise greatly increases physical and mental resilience. And this is critical for someone going through a cancer journey. Now, exercise oncology is a term increasingly being used, and this is when exercise medicine is specifically applied in cancer management. So this is a framework which was actually put together by Kerry Cornier and colleagues, and this, I think, very nicely describes the application of exercise oncology throughout the spectrum of cancer. Now, so we won't talk about pre-diagnosis, just to say that, of course, being physically active throughout life is very, very important for reducing risk of getting certain cancers, in particular cancers of the colon. But it's at this point of diagnosis here that exercise medicine becomes increasingly important as a pre-treatment. So what this is termed is neoadjuvant. In other words, it's applied before the main treatment. And here it is very much in preparing the patient for the upcoming main treatment. And some good examples here would be in preparation for surgery. So at this point here, we are, I'll just get my little marker up. So at this point here, we are getting the patient more resilient. We're improving their body composition. We're trying to improve their immune system in preparation for their surgery. Now, in treatment as well, the exercise medicine is said to be adjuvant. In other words, it is given at the same time as the main treatment. And so a good example here would be that it is given at the same time as chemotherapy. So patients used to be encouraged to rest when they were going through chemotherapy. That's been totally disregarded now. And the clear evidence is that patients should exercise throughout their chemotherapy phase. In particular, they should exercise immediately before or potentially even during receiving their chemotherapy infusion. And the same principles apply for immunotherapy and radiation therapy. Here, post the main treatment here is the recovery phase. And here we say that exercise medicine has a rehabilitative role. And a good example here would be post-surgery, where we're getting the patient up and moving as early as we can, trying to prevent the catastrophic decline in their physical function and structure, which often occurs after surgery, trying to improve their physical fitness and physical structure here. In the long term, we move into the survivorship phase, and exercise is important here for disease prevention. In particular, strong evidence showing that if the patient is physically active in this phase, they are much less likely to have a recurrence of their cancer. But also, we have to keep in mind that many patients will succumb to other chronic diseases, in particular cardiovascular disease. And so exercise medicine, again, is crucial at this survivorship phase to prevent the increased risk of other chronic diseases as well. And then at the end stage here, during palliation, when the cancer is no longer curable, exercise has a very important role here, particularly to maintain quality of life, to maximise the physical function of the patient as far as possible, and to improve their that end stage of life. And increasing evidence is indicating that exercise will actually increase the survival time. So patients are living with perhaps a better quality of life, with better function, and perhaps even a little longer. So I wanted to give some really recent research specifically in lung cancer. And this was a review published just recently, actually this year, September 2022. And this was published by two colleagues, Catherine Granger and Vin Cavalieri, both based here in WA, or at least Vin is. And this is a combination of several studies here looking at the intervention group, so an exercise group versus control or usual care, and their risk of developing a post-operative pulmonary complication. And what we see here that the overall effect that you can see here is about 0.39. So what that means is that the overall risk of having a pulmonary complication after your surgery for lung cancer is greatly reduced if the patient is physically active preoperative. In other words, these patients have been through a preoperative exercise program, and that's actually translating to their postoperative outcomes, which is really important then. This is in people with non-small cell lung cancer. This was duration of the intervention less than 2 weeks here, and then duration of the intervention greater than 2 weeks. And in fact, we don't see much of a difference here. So even quite a short intervention of 2 weeks or less has been quite effective. So that's important. You've got a window there before surgery where you can intervene with a high-quality exercise program and greatly improve the outcomes post-surgery.
Rob, just on that one, the intervention type, could you touch on, was that strength-based?
Oh, Katie, it varied quite markedly. You could see there was quite a large number of studies there, 1, 2, 3, 4, 5, 6, 7, 8, 10 studies. So it varied across those studies. Most were a combination, what was termed multimodal, so a combination of both aerobic and resistance exercise.
Great.
This is from the same systematic review here. And again, this is looking at preoperative exercise interventions. And in this case, it's looking at the postoperative length of hospital stay. So this is a very, very important outcome for the patient, of course, because the less time in hospital, the better. But also, of course, for the financial issues around the health costs as well. But interestingly, what we see here is a considerable reduction, quite a strong effect here of a mean of 2.24 days. So in other words, patients who undertook preoperative exercise actually spent 2.25 days less in hospital. Now, that's an enormous impact for the patient, but it's also a huge impact in terms of cost to the taxpayer and the health system. And just another study here. This is actually moving now to the post-surgical phase, and this is looking at the effectiveness of a rehabilitation program implemented after surgery in patients with lung cancer receiving a resection. And the data present here is the post-operative complication rates in the rehab group versus the usual care group. And what we see here, again, is quite a nice benefit. The odds ratio is 0.66. So in other words, looking at it another way, the risk of having post-operative complications is reduced by about 34%, which is an important outcome for the patient. That was all complications. This is for pulmonary complications specifically. And again, we see a nice effect here. It's much larger. The odds ratio, so your risk is reduced to 0.33. So in other words, you've reduced your risk of a pulmonary complication by 2/3 or 66%. I mean, this is a huge reduction in risk of these complications. Just wanted to move to another piece of research, and this is entirely different. This is actually a study done in animals, in mice. The reason I want to show it is that it is a preclinical work. So this is not in humans. And the reason I want to show it is that it's some of the early work looking at, well, what sort of exercise and what is the difference here? And what we see is that this is in a lung cancer model here. And what we see is that the tumour volume is markedly reduced in those animals that exercised. And but interestingly, this was a comparison of moderate intensity continuous exercise versus high intensity interval type exercise. So this is interesting because I'll show you some recommendations for exercise for patients with lung cancer. But this is just an early signal here that perhaps the high intensity interval exercise, which is used extensively with cancer patients, specifically in lung cancer patients, it might be that more moderate exercise. So if you think of like going for a walk or going for a cycle, for example, rowing, etc., but more at a moderate intensity but longer term. And there's interesting rationales for this, as how this might actually work, and I can answer that perhaps a little bit later. But they actually sacrificed the animals and had a look at the tumours within the animals. And this is the control animals. This is the tumour. And in the high intensity exercise animals, but in the moderate intensity, you can see here, tumour size is much smaller. So some interesting early data there. Again, this is very recent. This was just from last month as well. So another area of a huge research effort is to try and understand how exercise actually extends survival in patients with cancer. You can't really argue anymore that exercise medicine is essential for all cancer patients. The current recommendations nationally here in Australia, but also internationally, is that all cancer patients should perform exercise on most, if not every day of the week, and that is regardless of cancer type, stage, or even when undergoing difficult treatments. It is just the type of exercise and the dosage, if you like, which needs to be adjusted for the individual patient. But there's increasing evidence indicating that those patients that are physically active actually live longer. There's increasing evidence in animal models and now in human models that exercise somehow actually slows progression of the disease. It actually causes the cancer cells to replicate more slowly, or it drives the cancer cells to self-destruct or to die. Now, we published in 2016 some 10 proposed mechanisms by which this effect is produced. I won't go through all of them, but just point out some of the key ones. Certainly, we're doing a lot of work and other groups around the world on improved immune function. Many cancer patients, because they're sedentary, and some will have chronic inflammation, metabolic syndrome, and other disorders, their immune system is considerably compromised. And this means that it creates a pro-cancer environment. And the body really doesn't have the soldiers, if you like, to be able to fight the cancer. Exercise turbocharges the immune system. And when you exercise, your body pours out natural killer cells and other T cells, which are very, very effective at finding and destroying cancer cells. Also, exercise, I'll go into this one, reduces systemic inflammation and oxidative stress. I mentioned earlier that many people with cancer, they're just reflective of the general population. Many will be sedentary, may have poor diet, may be overweight. And this creates, unfortunately, a pro-tumour environment. Exercise helps to counteract that, and that's a very important effect. And finally, I'll just talk about this one here, changes in tumour vascularization. We know that in patients that are active, the actual blood supply to the tumour is better. It's more effective. It means that there's more oxygen being delivered, but also it means that more immune factors, more chemotherapy, radiation therapy is delivered. And this makes those therapies more effective, and it also improves the effectiveness of radiation therapy as well. So there's some other mechanisms there which I'm happy to answer questions on, but I think we'll keep moving. I think what's the key is to come out is that we now know that exercise is not a single medicine. There's many different types, modes and dosages, and we have to tailor the prescription to the individual if we want to get the greatest effect in terms of safety and also adherence. Next one. So in 2019, my colleagues and I released the Australian statement on exercise medicine in cancer management. And I just want to take you through a few key things here, because it was a considerable departure from the existing recommendations, which we actually published back in 2009. So a decade later, of course, an enormous accumulation of high-quality research trials and clinical information around cancer management through exercise. And we moved from a generic recommendation or prescription to a more tailored approach, involving assessing the patient, determining and prioritising their health issues, and then designing a specific exercise prescription to really target those issues which are causing the greatest risk of morbidity or mortality. Now, there are some foundation exercise guidelines. In the main, it will be a combination of aerobic and resistance exercise. So aerobic exercise you're familiar with, that's your jogging, cycling, swimming, etc. Resistance exercise means lifting weights or working against the resistance. It has to be a fairly high intensity. It needs to be a moderate to high intensity. We know now that doing light exercise just doesn't cause the exercise medicine to be released within the body, and it certainly doesn't drive the structural changes within the body that we're trying to achieve. Frequency should be most days of the week. You should spread the dosage. If you have a headache, you don't take a whole bottle of Panadol. you spread the dosage. So you take 2 tablets, and then 4 hours later you take another 4 tablets. Exercise medicine appears to be more effective for cancer patients in the same way. It's better to do a little bit of exercise each day than to run a marathon on a Saturday, for example. It needs to vary across the week and the month and around certain events. We periodise, this is called periodisation. We periodise the program, particularly around chemotherapy infusions and other key events as well. We have to take into consideration any acute or chronic concerns which might require specific exercise prescription. For example, cachexia is very common in people with cancer and also quite prominent in lung cancer. This is an uncontrolled loss of body weight, and it's a major problem causing considerable mortality risk for the patient. So we need a targeted program. This is resistance exercise. It is the only thing which is going to slow the weight of the loss of muscle mass. And we need to limit aerobic exercise because that will actually counteract that effect. Nutritional support's important as well. We also, in this paper here, which is free for download, you can also, we give specific requirements or recommendations around bone loss, such as osteopenia, osteoporosis, and also around obesity as well. So I'll keep moving because I'm conscious of the time. Now, in Australia, we're fortunate to have an allied health professional, which is the accredited exercise physiologist, which is approved through our Medicare system. And it's important in terms of referral to these allied health professionals. They're a minimum 4-year university educated with extensive clinical experience as well, and they're accredited by Exercise and Sports Science Australia. Now, AEPs are recognised with the Australian General Practice Network and Royal Australian College General Practice as the most appropriate allied health professionals for exercise prescription and management, prevention and wellness, and in particular secondary management of chronic disease, including cancer. Now in Australia, and I apologise to the people who are coming in from internationally for this webinar, but in Australia you can find an AEP on this website. You can put in your postcode, and then a special interest of cancer, and then your distance from that postcode, and it will give you a list of accredited exercise physiologists in your area. And I just want to finish off by just talking about telehealth, exercise medicine. So a lot of changes due to COVID, and it did force us and our team to pivot our clinical services and research trials, as it did Katie's team as well. And this was a problem, but it was also a huge step forward in terms of providing exercise medicine at a time and a place of the patient's choosing. And so there's been huge advances here in the use of video conferencing systems like Zoom or Teams here to actually deliver high quality exercise medicine supervised into the patient's home with online real-time monitoring as well. Very, very important. So we are now doing the assessment of the patient remotely and then designing up the exercise prescription, delivering it to their smart device or their tablet computer, and then monitoring them whilst they're performing their exercise programming. And individual sessions one-on-one, as Katie's team does as well, but also we're running group sessions, which are working out quite well. I think what's really advanced this, of course, is that the video conferencing systems moved forward markedly with COVID. If you remember back to the start of 2020, they were a little bit clunky, but that's all been overcome because it's had to, and they've advanced markedly, which has been a fantastic progression. Also, we've seen a huge advance in wearables and IoT, which is Internet of Things, biometric devices. So smartwatches, for example, there's a huge range of these now available, and the amount of technology that they can put into these devices, because they are consumer devices rather than medical, is incredible, and the cost price point is just so reasonable now. This is advancing things with capabilities around heart monitoring, heart rate, ECG, blood pressure, oxygen saturation, a whole range of metrics, which are just fantastic in terms of the exercise physiologist or the doctor being able to monitor the patient remotely. So I want to thank you for the opportunity. It's been great, and I think now we hand it over to Katie.
Thank you, Rob. I just, that was a fantastic summary of recent, really important research, but also insights into the clinical placement and differences between physical activity, exercise medicine, and how they're best prescribed with consideration of that whole person healthcare. I think before I wanted to invite some questions in. So please, if you have a question for Rob, could you please post those questions now while I just address my first question with Rob. And before I do that, I just want to welcome everybody. We've had enormous interest. There's over 65 people enrolled and registered and online. So I've known Rob for a very long time. And I remember when Rob was doing exercise medicine presentations at various cancer care centres with 1 or 2 attendees. And he delivered and repeated. And, you know, to be able to sit here now and deliver an audience for 65 for someone of Rob's calibre is extremely rewarding. Rob, because you always give such incredibly accurate and insightful and efficiently delivered information, I actually wanted to just turn my first address in question to you personally. Your motivation for your degree of engagement in oncology and what motivated you originally to start working in this space with your career, which started as a biomechanist for the Chicago Bulls when Luke Longley and Michael Jordan were there. So there's this enormous sporting career that took quite a grand pivot. I just thought you might share a little bit about that motivation.
So many stories I could tell, but I'd probably best not to. Yeah, look, I think what really motivated me was that my dad developed prostate cancer. He had a prostatectomy and then went for radiation therapy. And this is 27 years ago. And he was really weakened and fatigued by that. And he, told his doctor that, and no reflection on the doctor. This was the thinking at the time, and it was standard clinical practice. His doctor told him to rest. And he did that, and he sat in the chair in the sun at the front of the house, and he got weaker and smaller and less capable. And 2 years later, he died of a stroke. To be fair, I think if they hadn't treated his prostate cancer, he would have possibly lived longer, but certainly would have had better quality of life. As an exercise scientist, I knew that this was not right. The body is not meant to be rest. It's not meant to be sedentary. And so that's why I launched on a 20 years now of researching specifically exercise medicine applied to various cancer patients. The rest strategy has been rejected. There are times to rest, obviously, during the day. If you're feeling overwhelming fatigue, it is a good idea to rest, but you must be physically active every single day. If you don't, fatigue will only get worse. The fatigue that is experienced by cancer patients is not the fatigue that you have when you spend a day gardening or you go for a long hike. It's a different type of fatigue. It's caused by the disease effects and the treatment effects actually damaging the heart, lungs, muscles, and the nervous system. And the only way to counteract that damage is through exercise, because that will actually improve the capability of those systems.
Thanks, Rob. I think we're getting a lot of questions that are coming up. What we'll do is we will pick 5 of those questions. There is a really interesting query initially. Are there particular wearables you suggest? Now,
just remember, I don't get paid by anyone other than the university. So I have to promote ECU first off. Great university. Look, we use Fitbit extensively because for a price point, they have a really good range of measurements on them. I think the sensors are a little bit higher quality in the Fitbit. I mean, the ultimate is Apple. I mean, the Apple Watch is the leader, absolutely, but they're expensive, and we find them too expensive for our patients. So we do use Fitbit extensively, but Garmin as well is starting to catch up. They're releasing a new range, and also just this week, Samsung also released some excellent watches. We use predominantly Fitbit and Apple Watch.
Fantastic. This second question. I actually made a note of this, so thank you for this question with regards to the reference of moderate to high intensity exercise.
Sure.
What is considered moderate to high? And just, I think it comes back to also, Rob, that contextualisation of whole person care and the considerations of where the patient's at, any other comorbidities or any other considerations. But I'll let you speak to the moderate to high intensity.
In terms of moderate to high intensity, for aerobic exercise, your cardio type exercise, it's generally defined as a heart rate between 65 and 85 or 60 to 85% of heart rate maximum. It's also defined quite normally using radius of perceived exertion. So on a 1 to 10 point scale, we're looking at a perceived exertion of somewhere between 4 to 6, 4 to 7 on that. So that's somewhat hard to, yes, this is hard. We define it in terms of aerobic exercises using the talk test frequently. So when you're exercising moderate to vigorously, you should be able to talk, but only in very short sentences. If you can carry on a conversation like I am, you're not working hard enough. But if you're going, I think I'm dying, that's too hard. So that's for aerobic exercise. For resistance training, you need to be lifting a weight that you can only lift around 6 to 12 times. So the weight has to be relatively heavy to drive the structural changes and the neural changes that we're trying to achieve. In terms of the, you did mention in terms of relationship to the patient's individual situation. Certainly patients who are at a higher risk can exercise at vigorous levels, but it needs to be under supervision in the main. It depends on what comorbidities they have, but if they're at risk of cardiovascular events, for example, they really need to be in an exercise clinic and they need to be under the supervision of an exercise physiologist. But someone who is relatively low risk, they might be very low in level of their fitness, but if they're assessed as being low risk, then it's fine for them to exercise at home or in the park. It's not a problem, and they can exercise at high intensity.
Fantastic. Thank you for that great question. Rob, speaking a little bit about the idea of periodization of exercise medicine is a query, and I think this is a really interesting opportunity to touch on those different modalities and opportunities around breath work, mobility, strength, and cardiovascular, and how they interface together in that periodization.
Sure. So we've been periodizing exercise training with athletes for probably 2 millennia. The ancient Greeks and Romans used to periodize the training of the gladiators and also, of course, the Olympic athletes. So we just borrowed from that. And what it means is that the patient's same thing every time they come into exercise. So we have to change the intensity and the volume. And so, for example, it's just a very simple example is that if you train 3 times per week, then Monday might be a high intensity session, Wednesday a lower intensity, and then Friday, for example, if you train on the 3rd day, it might be a moderate intensity, and then you cycle that way across the week. We also actually cycle or periodize the modality. So in other words, aerobic versus resistance training. In the main, it's not ideal, particularly for patient populations, to exercise both modes on the same day or on the same session. And so we actually separate it out. So they'll do resistance training on particular days, aerobic conditioning, and other sorts of training on a different day. I think periodization is a whole presentation in itself, but I think certainly periodization around certain events. During chemo, for example, we will increase leading up, say, the 3-4 weeks leading up to chemotherapy infusion. We'll increase the volume and intensity of the exercise prescription. And then, of course, after the infusion, the patient will have increasing side effects or toxicities from the chemo for the next few days. And so we have to drop the intensity and volume back down again. And then we build them up again in preparation to get them as resilient as possible for their next chemotherapy infusion. So that's just another example.
Fantastic. Thanks, Rob. We've got a few, thank you to Lift Cancer Care Centre in Adelaide. I had the pleasure of meeting your CEO at the TOGA conference just recently. So it's great to see a lot of you out there. Really good question around that significant weight loss and limited aerobic capacity. Just wondered about the rationale behind, and this is a really interesting question around similar applications clinically around anorexia nervosa and sudden weight loss. But I'll let you speak to those contraindications.
Okay, so as you can appreciate, cachexia is a major medical issue, and it's an urgent one which has to be addressed. So it takes priority over everything else. And the issue here is that it can be due to the disease itself. So cancer, certain types of cancer, a good example would be cancer of the pancreas, for example, use enormous amounts of energy. Because the cells are dividing so rapidly and they're so metabolically active, they just suck glucose out of the bloodstream. And that means that there's the patient, rapidly loses weight. Now, there's also effects, obviously, of certain treatments which cause weight loss. And the priority here is to try and maintain muscle mass on the patient as far as possible. Now, that's why resistance training, particularly higher intensity, higher volume resistance training is recommended here to try and maintain muscle mass. Aerobic exercise is contraindicated because it only creates a greater imbalance, energy imbalance, so that the patient will only lose weight faster. And at this time, the priority is not about improving cardiorespiratory capacity or reducing risk of cardiovascular event. It is all about maintaining muscle mass on the patient.
And there's a number of other crossovers around eating disorders in those spaces and risks with that sudden weight loss and extra stress and load as well. Thank you for that, Rob. I think the query around experiencing breathlessness in relation to performing exercise and more so within higher intensity exercise.
Sure.
Yeah, I'll let you speak to that.
Yeah, I mean, this is a quandary at the moment. I mean, I presented that very early animal work showing that the tumour seemed to grow, the lung tumour seemed to grow more slowly with moderate intensity aerobic exercise. And that's logical because it's a greater strain, that you've got more, the lungs working more, there's more function being maintained. The problem is that patients with lung cancer don't tolerate moderate intensity continuous training very well at all. And so in the main, we implement high intensity interval training. So the patient goes quite vigorous for say 30 to 60 seconds, and then they recover for 30, 60 or 120 seconds. It's tolerated much better, and you have much less in terms of that breathlessness. And so that's the way in which we generally manage that, through the use of high intensity interval training. There's other ways in which also to address that through restricted breathing exercises as well, where they do have to work harder for inspiration and expiration. So that's effective therapy.
And the last question we have here is a very special welcome. We did see a few NHS email addresses on there, which sort of is the perfect cue, I think, into a question around working with the NHS to deliver exercise to prostate cancer patients. At the moment, this is all charity funded. So it's all not-for-profit donation funded. What do we need to do to justify commissioning by the NHS?
Yeah,
I think
we struggle with the same.
You have the first dibs on that, and then
Sure.
I'll close off on that, Rob.
Yeah, it was interesting. I presented a couple of weeks ago at a conference, the European Initiative for Exercise is Medicine. This came up extensively, including a number of representatives from the UK. We have a huge change which was implemented probably 12, 15 years ago. I lose track of the time. And what happened was we were able to get exercise medicine actually added to our National Medicare scheme. So what that means is that anyone can get consultations and support through an exercise physiologist, and the taxpayer supports it and pays for it. So it's an integral part of our medical system. The way in which we achieved that was that a number of medical doctors who lived in the electorate of the health minister of the time, later our Prime Minister, Tony Abbott, actually waltzed into his office, made an appointment, waltzed into his office and said, "What are you doing? These exercise physiologists are actually delivering exercise medicine and we're seeing great outcomes in our patients." Well, the result was 4 weeks later, it was written into law, and that was the change. So that was just I guess a little bit of fortunate way in which that was actually occurred. But that's the example of how we got exercise medicine integrated into the Australian health system. And it was through that one event. And also, to be fair, Tony Abbott was a bit of a fitness nut, or he still is. And I think that probably helped a lot. But it is about finding, you don't have to convince everyone. You just have to convince the person who's in charge. Now, in this case, it was the Minister for Health.
Yeah. And I think advocacy, and I think there's a few different, very much key drivers, including yourself, Rob, in that space of advocacy for exercise medicine. I know you played a key role throughout all of that. I think it's also thinking outside the square for funding. I think working with, for example, in our program, working with pharma, global pharma, and creating partnerships that support funding for such programs that improve physical and mental resilience and quality of life throughout all of those stages. So there needs to be, and I think that's where a little variation between being commercially sustainable to be able to keep delivering these services. I mean, Rob is also on our advisory board. You know, the incredible research that he produces out of ECU and throughout his career, being in a clinical setting as clinicians, to then be able to translate that research into viable, usable commercial programs that then set proof of concept for funding models is you know, this is what we're here for, right? This is what we're trying to achieve. So this is the space where we into all of the beautiful, very precise systemic reviews and the RCTs and all of the work that Rob's doing with many of his colleagues in the research space, then creating real world data collection opportunities that talk more to how people actually respond in real world settings to those experiences and to those prescriptive doses. And I think for most, there's a few clients that are in the audience tonight that engaged in this program, and a very special welcome to you. I think you, after digesting all of Rob's prescriptive recommendations, you know, being able to translate that to something that is effective in a clinical setting. I will introduce you to Courtney Dewhurst, who was the senior clinical lead on this 12-week pharma-sponsored exercise medicine program for 50 Australians with non-small cell lung cancer. And I'll let her speak to how we translated those recommendations by Rob into this community setting.
Thank you. Hello, everyone. And yeah, thank you for joining. And as Katie said, there's a few on here who were part of the non-small cell program, and it was an absolute pleasure to be able to provide this program to 50 individuals living with non-small cell. So earlier in the year, I had the opportunity to basically manage, on board, and then direct this program. It was a sponsored program for 50 individuals with non-small cell, and this was a program that was completed 100% virtually. So we had nationwide response, and overall sort of the percentage of participants was fairly even between the main states across Australia. And a big thank you to a couple of Facebook groups who also helped to promote that program and assist with the onboarding process in the early stages. So Katie and I were able to successfully onboard 50 individuals in 6 weeks, and then from there carry out the 12-week program. I was seeing these individuals 3 times a week over that 12-week course, and basically running through an individualized program with each of them within a group setting. And as Rob touched on before, it was each program was individualized, and I guess directed based on the individual's particular treatment plan, whether that was immunotherapy, chemo, radiation. It was about adapting to the treatment that arose. We successfully onboarded the 50 individuals, and we had an 82% completion rate of the 12-week exercise program. And this was very close to the statistics that we produce in our face-to-face exercise medicine clinic. So we aim to generate an 85% compliance rate for our programs. So for us, it was a good test to see how we went with scaling up in a virtual setting. Then where are we at? So this graph here is looking at the improvements in symptoms that individuals observed over the 12-week period. Now, what we see is we're looking at the week 4, week 8, and week 12. So a review and back session occurred at every 4 weeks throughout the program, at which point program was adjusted where required, and we gained these outcome measures. So what we can see is that at week 4, there were some significant improvements from the initial consultation. And then what we were able to see throughout as the program progressed, so more towards week 12, was there were greater symptom improvements, or greater spread of improvements in that we saw. So what was really nice to see was an improvement in, or an increase in, that sense of community and belonging, which I think was a very valuable the program was valuable in that sense.
It wasn't necessarily something that we anticipated. I think as Rob recommended and suggested with COVID, having 100% virtual, there are certain expectations that you are unsure will translate. And I think the timing of creating this sense of community in a time where clients were very much at risk and were spending a lot of time at home, having that sense of community was invaluable, and that social time.
Mm-hmm. And I think from what these symptoms improvements show is that we were able to provide improvements to the whole person's healthcare, so both mental and physical aspects of their health, which is huge, particularly going through treatment.
I think that just referencing back to Rob's recommendations, and interestingly, modality-wise, seeing interesting increased walking capacity, a continual improvement in that space, and a continual improvement in increased strength being the 2 key priorities in that area. Increased quality of life, again, continuous throughout that 12 weeks, as was energy and cognitive clarity, a huge increase there. So really, really highly correlated outcomes as far as your clinical research is concerned for real world observations. Very much the sense of the virtual care is the overall experience as far as professionalism, privacy, and outcomes. They were all very much either in line with or were greater than what we experienced face to face. So I think this is a really interesting observation with regards to comparisons for real world virtual versus face-to-face. And we were basically looking at like 3% variance caught in our face-to-face outcomes with varied conditions. Yeah. And we wanted to take this opportunity to say thank you very much. All of the participants have received this information, but it's really important to us, and this is why perhaps one of the reasons why Rob very generously supports our agenda is to talk to that 60% people that don't move enough to start with, and be able to use the opportunity of a diagnosis to help change your trajectory, as well as treat with clinical exercise medicine. So it's the ability to layer with physical activity and exercise medicine and the individual skills of an exercise physiologist, but more broadly and widely as well in a multidisciplinary team to generate the highest value-based health outcomes, including other allied health, physio, oncology nurses, oncologists, respiratory physicians, and of course, with the patient at the centre of all of that care. Thank you, Courtney. And Courtney has been with Chronic Care Australia since the day we started, and it was a very, very rewarding experience to see her. Yes, we recruited and onboarded in 6 weeks. So to start with that, it is very unusual, and our capacity to be able to do that nationally was extremely rewarding. But she did a superb job in that space. Rob Newton, thank you so much for your generosity, your experience, your worldly research, and we actually have the pleasure of getting Rob off the back of a European trip. He started travelling again and has demands on him for many varied conferences. So he's constantly got the most cutting-edge, succinct summary of the latest research. So thank you so much, Rob, for and to delivering this to a very important and diverse audience of allied health and people living with lung cancer, as well as other healthcare providers. So thank you so much, Rob Newton. Team, thank you for coming along, and we will be sending out all of the information that you have seen tonight. If you have any specific queries around research or any other questions that come up, please feel free to direct them to katie@chroniccare.com.au, and I will liaise with Rob and get directions. A lot of Rob's colleagues, Daniel Garveo, he is also up at the Vario Clinic at ECU, is superb, and their fully operational clinic up there is excellent. And quite often, because of where that's located and where we're located, knowing that there's quality teams north and south, it really makes sure that consumers are covered, which is lovely. Everyone, thank you very much for your time. We will email this information out, and we've got one new message down the bottom. Wonderful. Yes, thank you all, and have a wonderful night, and look out for our next, we will be looking at breast cancer as our next presentation, and a cardiac, community-based cardiac care presentation as well, Rob, in the near future. Thank you for your time, and we all a lovely evening.